Welcome back to the Medical Fitness Podcast. I'm Jeff Young, and today I'm not here with my co-host David Flench or Dr. Thomas Hammett. I'm going solo. Our special guest is Dr. Sarae Jandreau, who I met back in 2018 at an American Osteopathic Association annual conference when she was a medical student. So it's been great from my end to see her evolution over the past 7 years. Welcome to the show, Sarae. I look forward to our chat.
Hey Jeff, how are you today?
Yeah, I'm doing well, thanks. It's good to see you, and really glad that you're on the show. And I'm looking forward to our series of questions. So let me start off, and I'm just going to keep the first one broad and ask you, how about if you start by just describing your journey?
Absolutely. So, like Jeff said, I am a physiatrist. I am just finishing my last month of residency training, so about to become an attending physician. And my journey started all back at the University of New England, where I studied applied exercise science. I became a certified personal trainer through the National Strength and Conditioning Association, or the NSCA. And then by the time I graduated, I became a certified strength and conditioning specialist, or the CSCS certification. I spent the first 2 years of my medical school career actually as an assistant strength coach at UNE as I studied osteopathic medicine. And then I finished my clinical years, an additional year of teaching in osteopathic manual medicine and anatomy, and then went on to residency in physiatry, which is also known as PM&R, or physical medicine and rehabilitation. And so here we are today. I will be taking an attending position back home in Maine at the Maine Health Neurosurgery and Spine Outpatient Facility as an outpatient physiatrist.
That's awesome, man. So let's dig a little bit deeper into some of that stuff. CSCS. What and also what made you pursue the exercise science as an undergrad, and then what made you decide with the CSCS? And also, you were an athlete in undergrad, is that right? So if you don't
Yeah.
mind, touch on each of those things.
Sure. So, um, why exercise science, I guess, would be the first piece. So, athlete growing up, I did dance year round. I played soccer, ran for track and field, doing hurdles and sprinting mostly. And I always loved being active. And in my first year of undergraduate studies, I, had this thought that I was going to go to medical school, be a doctor. And then I realized that medical biology as an undergrad is not that enjoyable. It's a lot of hard sciences. And I saw some of my colleagues studying exercise science. They were in the weight room, they were learning how to be personal trainers, they were very active. They had the opportunity to do full year anatomy, they got to do internships, and I loved being hands on. And I was like, wait a second. Med bio folks who are going on to be doctors don't get anatomy programs or internships. That sounds like a great opportunity. And so I actually switched my major at the end of my first year of college. And I'm really glad that I did. I was active on a club rugby team in undergrad, and then I started doing more weightlifting, and then coaching at the same time. So I ended up kind of shifting gears from more formalized team sports into that one-on-one training environment or weightlifting with our friends and colleagues. So I decided to go on and get the two certifications through the NSCA to support what I learned, and then to become a better teacher in terms of passing that on to the people that I was working with or the athletes, because I saw how much of a difference that it made working with the athletes in the weight room with their fitness development, their performance on the field, and then knowing that I wanted to be a physician. How was I going to use that to then teach my patients later down the line with those same principles of muscle development, speed, strength? How do we keep people moving, and how to be an effective teacher for those things?
Yeah, something I don't think I've ever asked you, but are you familiar with the ACSM's certifications? Have you ever? And so, obviously they're a lot more on the clinical side. And so with now, like a compare and contrast, what are you glad, or I don't even know how to word this. Are you glad that you went the CSCS route? Or would you recommend to physicians? Like, do you think that physicians should get both certifications? Do you think they should lean more towards one or the other?
I think that's a great question. I don't think I have all the information I would need to fully make that recommendation. Our university program seemed to be more geared toward the NSCA. They did mention that the ACSM was around, but I don't think they were as closely affiliated with our program. We did go to the ACSM regional conferences every year. And so we were involved with that institution, but not as closely as with the NSCA. But I hear what you're saying, right? It lends itself more to the clinical side, which is interesting, particularly where most of our undergraduate class went on to physical therapy school, and some of them went into occupational therapy, and then a smaller subset became physicians or physicians' assistants.
Okay. And something else I'm not sure if I ever told you, but during my 10 years at Mount Sinai here in New York City from 2006 to 2016, one of the physicians or physiatrists that I work with was, I think she spent like 12 years as head team physician and medical director for USA Women's Rugby. So, I mean, obviously I actually trained with some of the national members who lived in New York. And, so good for you, man. That's a tough sport. So good for you that you did that because you couldn't pay me to play rugby.
And I think knowing what I know now as a physiatrist and brain injuries, I probably be less likely to play. Um, but at the time, I loved that it combined the aspects of fitness that I felt my body was geared best to, the speed of sprinting,
Yeah.
the strength that it took, and then the coordination and, communication between team
Yeah.
members. I really admire that part of the sport and, also really a little cautious about the dangers.
Yeah. Oh, that's awesome. All right, let's move on to the next question, which let's start getting into medical fitness. Where does your passion for medical fitness come from? And where did you even learn about medical fitness?
So, of course, with you being as one of my mentors, I learned about the Medical Fitness Association from you and your work with the podcast. But I think even without that being the formal name, when I was an undergrad, one of the internships I did was at a medical fitness facility. There were personal trainers, there were physical therapists. I don't know that there was a lot of medical oversight, but they worked closely with some of our local medical facilities to provide services for persons with movement disorders or persons with chronic disease. So we had a fitness class for people with Parkinson's disease, some of those fitness classes. We worked with folks who had diabetes or heart disease after they had finished cardiac rehab. But we also had, your everyday general folk weekend warrior come in for a little bit more of that personal training one-on-one. They had some group classes, and then we also worked with athletes. We worked with high school age girls soccer. So it ran the whole gamut of athlete to person with chronic disease or movement disorder that really needed more focused rehab to address their needs and their fitness needs. And so, even though it wasn't necessarily called a medical fitness facility, I found it a really interesting intersection between my undergraduate work, mostly from the personal training side, and what I wanted to do in my career, which was how do we help people from the medical aspect? And how do we help kind of bring everybody into the middle where they're exercising regularly and they can function with their day-to-day life, the things that they want and love to do. One guy
Yeah.
came in and just wanted to be better at his golf swing, right? And so he was working with the trainers to be better at that. And so I thought that was a great kind of inspiration for where I wanted to take my career.
Yeah, you actually described somewhat the facility that I worked at Mount Sinai in the sense that it was the whole gamut, like what you just said. And that's one of the things, again, that's my perspective, that was my experience, but that's one of the things I really loved because sometimes we'd have USA rugby players, high level athletes or high level basketball players, etc., coming in and rehabbing, and then you had the person in their 60s, 70s, or 80s with frailty or leaning in that direction and associated conditions and stuff like that. But going back to the ACSM and NSCA question, I am a big fan of both organizations, but my pendulum leans a little bit more towards the NSCA just because being that atmosphere and also working with again, physiatrist who was head team physician for USA Rugby, and our other our medical director is physiatrist who was on the Knicks medical team for 14 years and stuff like that. We just kind of our philosophy, as a matter of fact, the facility's name was "We Focus on Fitness," meaning that progression and performance and not being afraid of things like intensity and things like that, even if the person is 78, 82, etc. You obviously start at different places with the person, but we didn't back off from progression and the word that's a little too common in medicine, rehab, and fitness that I just cringe just even thinking about it, underdosing. So yeah, I'm glad to hear that you had that experience and again that you're CSCS and have your athletic background. It's part of the reason why we're having you on the show because you bring a really cool perspective to all of this.
Yeah, I knew we would get into the concept of dosing at some point, and I think we're going to talk about it a little bit later. Um, but that's definitely a theme that I see underdosing run through our practice.
Exactly right. Yeah, let's dive into that in a little bit. But before we do, let's just talk about physiatry because I know when I first started at Mount Sinai in 2006, I never heard of physiatry, never heard of physical medicine and rehabilitation. What are these physiatrists? And now,
Yeah.
as you know, I was involved with the AOC PM&R for a bunch of years, and I'm very familiar, and I'm a big fan. So, how did you hear about physiatry? Why did you make the decision to go in that field? Maybe if you want, and you don't have to do this, but maybe if you want, even like, because this intrigues me, DO versus MD, and again, you don't have to dive into that if you don't want to, but DO versus MD, why physiatry, and I'll stop there and let you chat away.
Sure. So I guess we'll start kind of chronologically. DO versus MD, deciding what type of medical school. So regular medical doctor or an osteopathic physician. I had some mentors before I chose medical school that were in both camps. And one of my big mentors growing up was actually a chiropractor. He was a family friend of ours who helped me through some sports injuries and treated me with manual medicine. And I later learned that my parents chose to take me to him rather than our family doc because they were worried that I would get put on opiates or strong pain medication for my injuries when I was young. And so having him as a mentor and as a practitioner really helped shape the way my athletic development continued, and also my philosophy about treating patients. And he was actually one of the people who saw it in me before I did, where he was like, "You're too smart, don't waste it, go to medical school, you like caring for people, you like, these aspects of medicine and osteopathic medicine." And funny enough, that's what one of his daughters was doing. And so I had chatted with her, and the more I learned about it through my undergraduate years, which was at the same university and on the same campus as the medical school, I learned that they had a great anatomy program, which, like I said, tailed off of my love for anatomy and biomechanics as an exercise science student. And so, them having a very reputable program, learning more about the biomechanics, not only from a fitness perspective, but from a treatment perspective, I found really fascinating. So for me, it was almost a no-brainer to go into that um, area where it really matched my philosophy on medicine and what I was interested in learning. I had some mentors who were MDs, and I know that they're good and bad on both sides of the fence, and I have no bias in that regard. But I had one who was like, "Oh, in a couple of years, like doctors won't even touch their patients. We won't need to do that." And I think they were missing the boat, right? Not only from a connection standpoint or a diagnosis standpoint, there's so much good that comes out of that connection. That and another conversation that was heavy against DOs. And I started advocating for DOs when I wasn't even accepted into medical school yet. And I said, okay, I think I need to go the DO route. And so, like I said, I spent an extra year teaching manual medicine and anatomy at my medical school. And I'm really glad that I did. I feel like becoming a resident now, I have so many more skills and being able to teach and teach my patients and my colleagues about that intricacy of how the anatomy is working and why that's producing what we see in clinic. Um, it's a whole nother level of understanding from what some of my other colleagues who didn't have that experience are able to kind of understand. So it's a different conversation.
Okay. And
Um,
I was just going to ask, so can you, just for the listeners, what is a physiatrist? Like what's the definition and what differentiates a physiatrist from other practices?
Yeah. So the MD in osteopathic medicine are two types of medical school. And then physiatrist would be one of the subspecialties that a physician then goes on to practice for the rest of their career. So physiatry started around World War II when we started seeing more veterans come back with brain injuries, amputations, also spinal cord injuries. So those are some of the big disciplines that physiatry treats. We also treat stroke patients um, and medically complex rehab. So basically, anybody who has an injury or a disability impairment that they need medical treatment for, and they need help with improving that function to then improve their quality of life. So we see people after they've had surgery. We see people after they've had a long hospital stay and they have new weakness or they have trouble with their bowel and bladder care, nutrition. We work very closely in an interdisciplinary team with the physical therapist, the occupational therapist, speech language pathology. We work a lot with dietitians. Social work, of course, is key for navigating care for these patients, often these very complex medical situations that change their entire life. And then psychology, obviously, is also a key part of that as they learn how to cope and change through what their body's going through. We then see people in the outpatient setting either after they've been hospitalized for a setting of rehab, or even if it's just episodic care for musculoskeletal medicine that's non interventional.
So it's broad.
It's very broad.
It's
Yeah.
very broad. So that's intriguing to me. I could only, this would be out of the scope of today's conversation, but that's really intriguing to me because then it just makes me think about, man, about med school, residency, and all that you had to absorb.
Yeah.
That's amazing.
Thank you.
So, let me jump to the next question, which is kind of related. It's kind of bridging or tying together, I should say, the field of physiatry and medical fitness. So, how about if you talk about why the field of physiatry is primed to incorporate medical fitness and build the bridge between medicine, rehab, and fitness?
Sure. So I think as a medical specialty, we're already kind of the bridge between medicine and rehab. We're working with the rehabilitation teams in terms of therapists and our medical colleagues who took care of them in the ICU or the other specialty care. Um, and I think with my background in fitness, I see how those all intersect really well. Particularly, like you mentioned, with when we're talking about dosing of therapies. Um, we often see in our practice here that we have such specialized therapists that they kind of take on the ownership of what's the appropriate dosing for our patients. And we know that most of these therapists at this level are, doctors of physical therapy. They have master's degrees or higher, so that is specialized to their wheelhouse. And I still see that some of our physiatry colleagues aren't as comfortable with the dosing recommendations or the specifics in and outs. But I do think that, particularly where musculoskeletal care is a big part of what we do, and even treating a stroke patient for their shoulder pain after, right? That's musculoskeletal care. Or their spinal cord injury and they have chronic back pain because they're sitting in their wheelchair all day long, and rotator cuff dysfunction because they're propelling their manual wheelchair. So a lot of that falls into what we do. And when I think about the patients who come back to me and say, therapy didn't work, okay, what do you mean by that? How often did you go? What kind of things were you doing at home? And then I see the disconnect between the dosing. Did they go once a week? They didn't do their exercises in between, but there's a disconnect between that conversation of, do they know that it was important? Do you know why? Or were they practicing at home but didn't have the guidance for their biomechanics? And so I think, we as the physicians are seeing them at the evaluation and after the therapies. And then we see them when they're done with physical therapy, their course ends, and then they go on to the real world? Are they at their job again? Or are they engaging with fitness services? Are they not engaging with either of those things? And they're mostly sedentary. And so then we see them again at another checkpoint and we see how they're doing. Did they continue to be engaged in fitness and get better? Did they not do anything and get worse? Or did they do something and still got worse? And so I think as the physician, and we always talk about physiatry being kind of the quarterback on the team coordinating these services, are we seeing, how the patient is doing and what can we do about that? Who's the appropriate next provider that needs to support this patient on their journey to improving their function?
Yeah, and so again, this is what makes you special and different, at least in my experience, because you're not just stopping when they say, "Oh, I didn't get better," and you're digging deeper, and now it goes back to your background as an athlete, goes back to your background with exercise science and CS, the NSCA certifications and stuff like that. Is that then my guess is, I'm obviously just guessing, but my guess is all those things then helped with you understanding that you got to dig deeper and that there's the frequency, the intensity, the duration, and all those variables. And so, yeah, this is why I'm so passionate about the fact that on our end, fitness professionals, we need to learn more about what you do, not so that we can do what you do, but so that we can speak the language and understand better what's going on, and then vice versa. And again, that's what makes you different.
Well, and that's what we see in medical training, right? We spend time with folks from many different disciplines, surgery, infectious disease, internal medicine. We have to rotate through all of these different specialties so that we know when we see a patient who just went through that surgery, we can counsel them on what it's like or who they need to talk to at least, and ask some of those deeper questions to make that handoff between professionals more effective for the patient. And so I think, like you said, knowing what are those questions to ask to
Yes.
parse out some of that information from the patient, the client, to help them be successful rather than just, oh, you didn't do your exercises. Okay, next. That's not going to be what's effective long term.
Yeah, which is a perfect lead into the next question because you said you're a month away, and so you're getting ready to start your own practice. Maybe you can talk a little bit briefly about, or just remind me and the listeners more about this practice that you're getting ready to start, the environment, the atmosphere. But within your own practice, how do you envision incorporating medical fitness and bridging this gap?
Sure. So my role is going to be primarily an outpatient physiatrist in the disciplines of spine and musculoskeletal care. It's working within a kind of larger outpatient practice that is with general physiatrists who see some of the other subdisciplines and neurosurgery. And so we work together with the surgeons to evaluate folks for their spine pain or spine complaints, and counseling with their therapy options is a big part of what we do, in addition to some procedures. Um, so within that practice, like I said, counseling on therapy is always a big part. And, I really work that medical fitness conversation into my counseling of patients, talking to them about what is physical therapy? What's the goal? How frequently will they go? How frequently do they need to participate in their exercises outside of that appointment with the therapist, and why that is important? I know you know this as your background that the dosing is important. So the first 6 to 8 weeks is when we see neuromuscular reeducation, right? That is the basis and not the end goal.
Yep.
Most therapies are approved for once or twice a week to 6 to 8 weeks. You're barely getting outside of that neuromuscular reeducation period. And if they're only seeing their therapist once a week, they're probably not getting enough guidance as somebody who may not have ever exercised in their life
Yep.
to know what to look for to coach themselves for proper biomechanics to then alleviate or prevent their pain from worsening. So we see people that come in sometimes who say, my pain got worse with the exercises, I stopped doing them completely. And we know that that doesn't help. Or they did it for 8 weeks and they did it every day, but their squat form and their knees are completely together over their toes. They can't squat more than 45 degrees. They're like, oh, it made my pain worse. I don't want to do that again. but we know that that wasn't optimal training for their neuromuscular system.
Yeah.
So I'm really hoping that part of what I do is the counseling piece for my patients on those kind of key aspects, but also talking to my colleagues about it, seeing where they are, do they understand those principles, and then reaching out to kind of the larger health system about those principles as well. Um, for this particular practice, their therapy services, there's a few in-house, but there's much more availability of providers in outside kind of mini organizations around the city. And a lot of them actually are colleagues of mine from my undergraduate years who became therapists. So I'm hoping to reach back out to them to have a better collaboration and really understand what it's like from their perspective as a therapist, treating these patients on their end. What's working, what's not working, what can we do as a healthcare system in that area to make it more effective.
Yeah, this is great, and you're really touching on some things that I'm really passionate about. Two examples, if I can remember. One is that one of the co-hosts of the Medical Fitness Podcast, who's not here, Thomas Hammett, he and I co-presented at an American Physical Therapy Association annual conference, their combined sections meeting back in 2021. It was a 7-hour pre-conference presentation, and so Thomas presented for 3.5 hours in the morning, and he set me up, and I presented for 3.5 hours in the afternoon. And one of the things we talked about a lot of things in 7 hours, but one of those things was that physical therapy is a pit stop, and that I would say in most, if not all cases, a pit stop. And like you touched on, uh, the frequency might be low. You're only there for X amount of weeks. It's a start point, and there needs to be progression afterwards. And then tying that together with a theme that's we've already hit on during today's podcast is digging deeper. And I can tell that that's something you're really good at because I love it. Then that's what you need to do. I'm another thing I'm really passionate about is we just allow too much subjectivity and taking people at their word. And you know what? It's not that people are lying to us. It's just that they might not know enough. And so digging deeper is actually a way to educate as well, because they've never been asked these questions before, and it gives you a chance to educate the patient as well. So digging deeper to find out, tell me more then about how often you went, or were you doing your homework, or show me the exercises you were doing and the form that they were teaching you, or whatever, however you go about it. But digging deeper to find out, because if something is properly dosed and the form, the movement quality, the exercise technique was there, it's going to be a rare situation where you're not getting significant benefit from it. So again, I'm really passionate about this, and so I'm loving hearing that you are a master at digging deeper, and also that you want to talk to other physicians about this. Sounds to me like you have the educator, as part of your DNA as well.
Yeah, I've got the bug to teach, that's for sure.
Yeah, no, that's great. Okay, so let's start getting down to more what's going on. You already touched on it, but I'd like to dive a little deeper if we can, at the physician-patient level. So at that level, what do you think physicians should know about incorporating exercise into their discussions with patients and moving patients through the stages of change, especially if this is a skill set that they don't currently feel comfortable with? And before you answer, we talked about this before I hit record, but I'm going to admit to the listeners that I purposely put this question in because this relates to my dissertation. I'm a doctoral student right now. I'm wrapping it up. And this relates to my dissertation, which is really focusing on the clinician-patient interaction. And again, I can only go off my perspective, which is based off my experience. But in my experience, the clinicians, and I'm not just talking about physicians, I'm talking about a spectrum of care, nurse practitioners, physical therapists, et cetera, didn't feel comfortable with talking about exercise, in the office. In some cases, it was just they didn't feel comfortable. In some cases, it was they didn't have the time. The patient was coming in for something else. So how do you, since you're passionate about this and skilled at it, how do you plan on addressing this level?
The Medical Fitness Podcast is brought to you in part by the Medical Fitness Association. Are you a professional in the medical fitness industry? As a member of the Medical Fitness Association, you'll unlock exclusive networking opportunities with top experts in the field. Access cutting-edge education to stay ahead of industry trends and best practices. Don't miss out on the chance to advance your career. Join the Medical Fitness Association today. Visit medicalfitness.org to become a member. That's medicalfitness.org.
Yeah. So I think the biggest thing for me is just, I added in as one of my routine questions that I ask of everybody is, what are you doing for physical activity or exercise? And, we do a lot of training with other things like asking about substance use that just is that very neutral language, right? A lot of people tie a lot of emotion in about exercise or weight or shaming, depending on their past history, and just making it as neutral as possible and almost like it's an expectation I feel like comes out a little bit in that neutrality. What are you doing for exercise? And just as a prompt of like, oh, maybe I should be exercising or being a little bit more active. Some people will say I walk my dog or I have too much knee pain to really go more than a couple of blocks. But at least they're telling you then what they're doing day to day, or they go to the tennis club or they're playing pickleball nowadays. You can start to get an idea for what they are doing now. Particularly in our practice, a lot of times pain is a limiter, and that's why they're coming with the physician. So asking what did they like to do before? What would you like to get back to? Or what did you previously enjoy as a way to kind of move them in that direction of how do we get you to do that thing you like again? That's active. And then you can kind of see where are they in the I've never exercised before all the way to I'd like to exercise again. I know I should, but I'm having trouble with this. So if you let the patient talk, they'll often give you what they like, what their barriers are, or if they're really just not interested or they don't understand. Or if they've got really big barriers like work or medical things, and then that way you can start kind of parsing out from there what are those sub questions you need to ask to dig deeper and really find where they are so you can meet them with the level of resources that they need. One of the ways that I'd like to start working this into my practice, I don't know if you heard the ACLM or the American College of Lifestyle Medicine has now put out their screening tool for their 6 lifestyle domains into the medical health record, which is called EPIC. That's one of the most widely used. And so I've already talked to my new boss about wanting to build that into our system from the get-go so that I can track these metrics for my patients so we can see how people are doing as they progress, but also as a thing for patients to fill out before they even get in the office. So it primes them to start thinking about how am I sleeping, what's my stress like, what's my nutrition, and how much am I exercising? Here's the guidelines. Am I meeting those guidelines? And then they can kind of come in and ask like, hey, what's this all about? I never knew I was supposed to be strength training 2 times a week
Exactly.
or doing 150 minutes of cardiovascular activity. What does that mean? I want to be more active, but then we can really start the conversation because a lot of times if you prime people to get thinking about it, then you kind of plant the seed for them to be more prepared to be on that journey of change.
Yeah. And again, so here we go again. Like the tagline for my company is create an informed consumer. And that's literally what
Yeah.
you were just talking about. We need to create informed consumers. And so yeah, this is great. Here's an informal survey question,
Okay.
a one person survey question. But I'm curious, as I am not a clinician, so I don't know what it's like to go through med school and residency and stuff like that. Talk to me a little bit about developing a skill set. How did you develop a skill set for motivational interviewing? Do they talk about it a lot in med school, in residency? Like, where did you learn about this? Um, well, it's definitely a skill set. So it's something there's a learning curve and right. And so maybe you don't feel comfortable in the beginning, but then you get more comfortable. So maybe if you can just talk about that out of I'm just really curious about that. Did you feel comfortable? Like, where'd you learn it? Did you feel comfortable right away? It is how big was the learning curve for you, and is it getting easier and better and something that you really feel passionate about?
Yeah. So I feel like a motivational interviewing is mostly informally taught throughout medical training. It's definitely come up a few times, been recommended the book by a few folks. I think we talked about it some on probably the psychiatry rotations, right? Where counseling is a big part of what you do. And I feel like our mentors demonstrate it in different ways. So I definitely was, more scared of the content than the motivational interviewing, I think, piece at the beginning, just because you have to gather so much information. And that's really the
Yes.
skill that they teach early on in medical training. And I think having the background to teach anatomy and my knowledge in musculoskeletal care from my background made that subdiscipline an easy place for me to start with the motivational interviewing, because I had the content knowledge to back it up, to know what questions to ask, which ones were important. And then I actually did a ton of work through the last 10 years for my own, personal development. And part of that was the motivational interviewing and the behavioral science part of behavior change and trying to improve my own lifestyle habits. And so I think the combination of the exposure of patient after patient after patient trying to learn these things, having some good role models, and then that personal work and development really kind of has funneled into this thing that honestly, some days I still don't feel that comfortable about, but other days I feel great. And it kind of depends on the patient where they are. If they're pre-contemplative and they're not even thinking about change, of course, that's a little bit harder. And you might not get as strong of a foothold in that direction as you want. I actually had a great example of this recently with a rotation that I was on. One of the docs I was working with said, that this patient didn't have a lot of trust because of some of past occurrences with the medical field. And she said, I'm going to meet with him every month until he, gains enough trust in me and my desire to help him reach this next step so that we can improve his situation. And she did. We brought him back a couple of times in a row, and just to see, even by the third visit, how much more confident he felt that she was genuine in her approach. And then the counseling, and even just on that third visit, I was with her. We kind of planted the seed early in the visit, and he was like, "No, I don't want that treatment option." And by the end, he was like, "I think that actually might be a good choice." So the trust and explaining why it was important got us so much further. So I think you start to learn how to build rapport with people and how to pull out what's important to them, and then putting your education toward supporting the patient in that goal has helped us be a lot more successful.
All right, so here's another question, which was not part of our question list, but I'm going to ask anyways, because I'm just curious. I like to try to imagine what it's like to be in, like, in this case, your shoes. Correct me if I'm wrong. The patient is kind of being prompted via intake forms, right? So the intake form is asking them questions about their exercise, or maybe educating them a little bit about the guidelines. And so,
Mhm.
again, correct me if I'm wrong, but it seems to me that if that's the case, that's then helping you, because then when they're in a visit with you, they've already seen this information, so it's easier for you to prompt a discussion about exercise. But now we get into the time component. They're there for certain things that might not have anything to do with exercise, and maybe they're pre-contemplative. So you have someone who's pre-contemplative. They're there for something that has nothing to do about exercise, but you did kind of set things up a little bit via the intake form, but you only got 20 minutes, or I don't know how long you're going to have with patients or whatever, but maybe you only have 20 minutes or whatever. So put me in your shoes. What do you do in that situation? Is it just one question and then you hope that, as you see them, you build on that over the course of time, or how do you approach that?
Now, I'm a little bit more sneaky and intentional about that.
Good.
So we're having a conversation. I'm getting to know the patient probably for the first time. You know, let's stick with we're in a musculoskeletal outpatient clinic. So they're coming into me for pain or decreased range of motion. They can't do something functionally they want to do with that pain. And so oftentimes I'll ask them about, what is it? How long has it bothered them? And what do you do at home to help this be better? And one of the ways I ask about that is, so what sort of exercises or therapy experience have you in the past to keep, the muscles around that joint strong? And a lot of times that kind of gets some head tilts of,
Yeah, good.
oh, anything about that. And so we move on to the physical exam. So, right, I check their strength, I check their sensation, reflexes, and oftentimes we'll do special maneuvers to check for certain weaknesses or imbalances. One of the things that we check a lot for in spine and hip pathology is kind of our glute medius strength, right? A lot of people are weak in those stabilizers of the hip, and those oftentimes will, predispose somebody to having more pain. And so that's one of the ways that we say, oh, like some of these muscles are weak, and, see how being in this position really makes your shoulder pain worse, for example. And so we'll use those key components of the physical exam to support our counseling in saying, this is why I think engaging with physical therapy with this intention is really important. And that continuing your fitness to build the strength is important, so that we are not only thinking about how do we get you out of pain right now, but how do we think about what are you going to look like in 20, 30 years in the future? Are you still going to have the strength and the mobility to do the things you want to do? And talking about how, this needs to be a lifelong journey of building strength, because if we are sedentary, we're going to lose muscle strength, lose mobility over time, range of motion, and pain will often get worse with that. And I think when you help them forecast into the future, they stop thinking about my pain hurts, I don't want to move right now, which then compounds over time into that pain and weakness, to how do I set myself up to build myself for a more positive future? And if you're willing to partner with them on that and give them the education on how it's possible, you get a lot more buy-in from those people.
Yeah, this is great. So as you're talking about this stuff, I'm thinking about this is an advantage that you have having chosen the field of physiatry, because you get to talk about these things as compared to, say, I don't know, uh, a cardiologist who's there for the cardio, not so much the neuromusculoskeletal system. I don't know if that's a good
Yeah.
contrast or not. Yeah, so this is really good stuff, and it leads into what's probably going to be the last question before we wrap this up, and that is, what advice would you give to physicians, whether professionals in training or attending physicians, about anything related to medical fitness, building the bridge between medicine and fitness, or anything like that? I know it's a broad question, but I just wanted to kind of
Yeah.
end with that.
I would say, ask the question of your patients, ask the question of your colleagues, see what the culture of it is. If you're looking for more advice from your colleagues of how do they work it in, do they talk about it at all? You know, on your podcast, you've talked about a lot of different subdisciplines, and exercise applies to everyone from every subdiscipline. So I think in most cases, most physicians should you bringing this up, and if they don't feel comfortable, do you know who to ask for help, whether it's your local physical therapist, your local physiatrist? I think that's one of the big lessons we learn in medical training, is just figuring out who do you talk to when you don't know the answer. And that's okay, not everyone has to be a specialist.
Yep.
I would say ask the question, talk to your local folks, just like I plan on reaching out to the new physical therapists and people in my area, and just being involved. Like if this is something that matters to you, how do we improve the outcomes for our patients, and our society as a whole? And so I think, being engaged and being a good community member, whether you're in your own fitness facility, and then talking about how this can apply to your patients, I think, being involved and having that conversation is one of the biggest things.
I am going to ask one more question. It's a little bit loaded, but I'm going to ask it anyways. When I was involved with the AOC PM&R, a lot of things I would talk about, that medicine to rehab to fitness continuum, and I would say,
Mhm.
at the physician end of that continuum, you're the quarterback. You're doing your thing. Sometimes you're doing the treatment yourself, where the patient doesn't need to move on to rehab, for example. But in the situation where you're then referring the patient to rehab, are you in your practice going to, like, how are you going to determine from your quarterback standpoint whether or not that patient needs to be moved on to fitness, how they're being moved on to fitness? And let me say one other thing. When I first started Mount Sinai in 2006, and I didn't have the trust of the physiatrist that I worked with, because you got to gain the trust. and I didn't have it.
Yeah.
And so there was no such thing as the physiatrist referring directly to me. If I had a patient, it was referred directly, it came through physical therapy. But the longer I worked there and the more I gained their trust, there was some times where they felt like, hey, this particular patient would actually probably benefit more from being referred directly to Jeff to get total body strength and conditioning. Maybe it was because of non-specific low back pain that was mild, something like that, or mild patellofemoral syndrome or something like that. So it's not like it was an acute, more severe situation, obviously. But how are you going to navigate that? How are you going to make sure that you're connected to to fitness trainers, and or that the physical therapists that you're referring to are connected with fitness professionals so that that continuum can then be completed?
Yeah, absolutely. I think this is something that I started to work on even within my residency training, just because we have so many therapists in-house. So we're lucky that the communication is very streamlined. We're all in the same umbrella for the most part. And so we get notes from therapy. Sometimes they will contact us directly about a patient if they are concerned that, maybe they have a new medical need, or that, that they need to be evaluated for. Or if they're doing really well and they think they're graduating therapy, but maybe they're worried about them being able to continue engaging in their exercise program or progressing that program when they're done with therapy. Like I said, maybe they're there for 6 or 8 weeks, and maybe the therapist didn't progress them beyond doing a clamshell for a healthy 36-year-old who's very strong. And a
Yeah.
clamshell's not enough intensity to build that strength. And so oftentimes I've been the one to throw that out to my attendings to say, hey, I think they need to do fitness. Can they be engaged at our medical fitness center? Can we send them somewhere? Um, and there are some independent practices here that have fitness professionals that are a little bit more communicative with our team. And so I think with my new practice, what I'll be doing is, if the person comes in and say, this is the gym that's closest to my house. Great. Can I talk to them? Would that be okay with you? Can we sign a release that I can ask them about their skills at least? It doesn't even have to be specific about the patient. Can I ask them about their skills or how they're interacting with the person? That way we can get that communication back and forth between professionals and start building that rapport and trust so that we know that they have the skills necessary to serve this person, or that they're going to be able to be engaged beyond the therapy window. I know you guys have talked on the podcast before about some of the resources online about seeing who's a qualified healthcare professional. I know you have your service for your own business that kind of helps screen for that. So I think in a capacity that'll probably be part of how I'll be integrating that into our practice, just to say, these are the people in our area that I know have the skills, qualifications, and can trust. But if you live 2 hours away, can I at least call them on the phone and have a discussion and see if that's something they're comfortable with? That communication is so key.
Absolutely. And you know what? We need to wrap up, but I am going to use that to put a little bit of a plug in for myself because, again, this is something I'm also just really passionate about. There's credentials and there's competency, and sometimes they match and sometimes they don't. People can, and just focusing here on fitness professionals, a fit pro can have all the letters after their name and certifications that they want, and it doesn't necessarily mean that they're competent. And the way you bridge the gap between in my opinion, the way you bridge the gap between credentials and competency is what you just touched on. You got to vet. You got to vet the person, but then that opens up another can of worms. How do you vet the person? Vetting is an interviewing process, really. When you break it down, is you're interviewing the person. It might be an informal interview where you're just asking them questions, but you're still interviewing them, and you're still trying to find out what they know and what they don't know, and if they're someone that you're going to trust or not. So you have credentials, competency. What bridges that is vetting, and vetting is also a skill set. And again, you have a background as an athlete, exercise science, CSCS, and all the associated things that give you that skill set to know what questions to ask. But there are a lot of clinicians, and again, not just physicians, but clinicians across the board who just don't have the background and they don't have the confidence to vet. So I'm going to use that as a way to say, I will help you. So send me an email and I will absolutely. That's one of the services that I provide, is to help, whether it's someone in person or virtual. I will help you vet the trainers in your local situation if it's in person, so we can help bridge that gap. But with all that said, I need to wrap this up. So, first of all, thank you so much for being on the show. This was a great conversation, very informative. Really glad you were on the show. And for the listeners, how can people learn more about you and follow you on social media?
Sure. I would say I'm probably not the most active on social media right now, just with being through residency training, but I am on LinkedIn. You can find me at Sarae Jandreau there. And I'd love to hear from you. So shoot me a message and we can connect, and would love to help with this medical fitness journey for you and wherever you are.
Yeah, I'll make sure to put that in the show notes. So again, Sarae, thank you so much. It was a great conversation, and look forward to talking to you in the future.
Yeah, you too, Jeff. Nice to catch up. Thank you.
This episode of the Medical Fitness Podcast is brought to you by the Medicine, Rehab, and Fitness Institute. The MRFI has been co-founded by medical, rehab, and fitness practitioners who see the medical necessity in getting people to be more active and fit. There is a sleeping giant of opportunity to building a more active population, an opportunity which lies in a more effective medical referral pathway to exercise programs and professionals equipped to serve that pathway. To learn more about our services and how we're working to make this a reality, visit mrfinstitute.org. That's mrfinstitute.org.